So now let's move on to the tool and to the domain dedicated to measurement of the outcome in the tool. So for this domain, we have 5 different signaling questions. Most of the signaling questions are related to blinded, and you will answer to different signaling questions, and you have a complex algorithm that will allow to classify this domain as high risk, some concern, or low risk. I really encourage you to have a look at the website. There is a specific website dedicated to ROC2 where you can see the full guidance for all the domain. And you can also have access to an Excel file. You need to download it to be able to use it, where you can answer the different questions, and automatically the algorithm will provide you the assessment. You will be able also to change this assessment if you think that you don't agree with the algorithm. It's also important to highlight that this assessment should be done at the outcome level. So for one study, you will have to assess this domain several times. Let's move on to the signaling questions 1 and 2. So the first signaling questions is, was the methods of measuring the outcome inappropriate? So this relates more on to non-differential errors. So what are we going to look at? First, we are going to look at the validity of the method. And we're going to answer yes if there is a poor validity of the method. A poor validity of the methods means that the methods for outcome measurement does not measure what it is intended to measure. Let me give you some examples. First, you would like to, your outcomes is severe hypoglycemia. In the trials, they decided to use as a measurement tool a specific device, which is a portable blood glucose machine that is used by patients. However, you know that this tool, this machine, does not reliably measure hypoglycemia of less than 3.1 millimole per liter. So you know that this device won't be able to detect a very strong hypoglycemia. And you're really in a situation where you will have an under-ascertainment of the outcome. Another example, a lot of study aims to measure the physical activity of patients. And for a long time, we've been using self-reported physical activities. And there has been some studies showing that some of the questionnaires that are used to measure physical activities have a very low and very poor validity. So it's not going to measure adequately the actual physical activity of the patient. Another issue that might arise is the poor reliability of the methods, meaning that if you're measuring the same outcome several times, you will systematically find different results. So again, a tool or a measurement methods for the outcome that has a poor reliability is going to be considered as an inappropriate method. Just some warning for these questions. It's really important to keep in mind that these questions does not aim to assess whether the choice of the outcome is relevant. So you're not trying to see whether it's a patient's relevant outcome, a surrogate marker. This is not what we are looking for. And overall, in most of the trials, the answer to the questions will be no, probably no, at least for the pre-specified outcomes. It will be yes, probably yes, only, so meaning that the methods for measuring outcome is inappropriate, only if the measurement that is being used is unlikely to be able to identify a plausible intervention effect, or if you have some clear evidence that it has a poor validity. So if you answer to this question, if you go back to the algorithm and you answer to this question, yes, probably yes, straight away, this domain will be high risk of bias. You don't even have to answer the other questions. If the answer is no, probably no, or no information, you move on to the second question. So the second question is, could measurement or ascertainment of the outcomes have differed between intervention groups? Usually in most randomized control trials, outcome assessment is really standardized. I mean, everybody has got the same time point. The organization is very straightforward to make sure that outcome measurement will be similar between the different groups. However, specific situations may arise. For example, in some situations, because of the logistic of the study, you may have different outcome assessors. For example, in a study where the goal was to decrease, to improve the blood pressure for patients with an intervention that involved some pharmacists who did provide some advice to patients. Because of the organization of the study, the experimental group was evaluated by the pharmacist, while the control were evaluated by trained interviewers. There is also a major issue related to diagnostic detection bias. For example, if because of the interventions, you're going to have more visits to the physicians because of the way the intervention is organized. Well, by definition, if you have more visits to the physician, there you are in a situation where the probability of detecting an outcome event is going to increase. A third situation is when the treatment, the experimental treatment, has some specific adverse event that will result in complementary tests that will be more frequently performed in one arm compared to the other. For example, there are some treatments for hypertension that will be responsible for growth, and so chest radiography might be performed more frequently, and the likelihood of detecting issue on the chest radiography will be more frequent in one group compared to the other. So to this domain, to these questions, you answer no, probably no, when the methods of measurement are the same in each group, with the same definitions, same time point, same assessor. It's going to be yes, probably yes, mainly when you are in the context of a passive collections of outcome data, such as adverse event, or additional visit in one group that are not planned in the other. So here you have the algorithm. If you answer yes, probably yes, you go straight to high risk of bias for this domain. And if you answer no, probably no, or no information, you will go to question 4.3. So now we'll move on to question 3 to 5, and perhaps before as John Rogerson starts his presentation, I can answer a few questions, if there are some.
Yeah, brilliant. We have one question from Ruth, and that was around the signaling question 4.1. And she says, poor validity of the methods. Does this overlap with indirectness in grade assessments?
I don't think it overlaps with indirectness in grade assessment. That would be my answer. It's going to be really it's going to be really specific situations where really the methods used is not at all appropriate for detecting the outcomes. So it's just in situations where you're using the completely wrong device or the completely wrong questionnaires to be able to detect your treatment effect.